Remember that in addition to accurately characterizing the degree of aortic stenosis, echocardiography also provides assessment of left ventricular function and assessment of associated valve lesions, including aortic regurgitation. We will devote the remainder of this tape to discussing the echocardiographic assessment of aortic regurgitation. Aortic regurgitation results from various etiologies, which can be determined from 2D echo evaluation of the aortic valve and aortic root. The detection and evaluation of the hemodynamic severity of the regurgitation is assessed by a combination of pulsed, continuous, and color flow Doppler techniques. The functional significance of the regurgitation is assessed via 2D and M-mode evaluation of left ventricular size and function. Therefore, the comprehensive assessment of aortic regurgitation requires a detailed 2D and Doppler evaluation. We will begin with a discussion of detection of aortic regurgitation and then discuss the assessment of hemodynamic severity. The various etiologies of aortic regurgitation will be demonstrated throughout this discussion. This patient has rheumatic mitral and aortic valve disease. Note the hockey stick appearance of the anterior mitral leaflet. Both the mitral and aortic valves are thickened. For detection of aortic regurgitation, a pulse sample volume has been placed in the left ventricular outflow tract. This is the resultant pulse Doppler spectrum, which confirms the presence of aortic regurgitation. The signal is holodiastolic, and the filled-in envelope indicates turbulence. The turbulent regurgitant flow is multidirectional, so we are able to easily detect it even from this peristernal vantage point, which is nearly perpendicular to the left ventricular outflow tract. The aortic regurgitant jet is characteristically high velocity, which results in aliasing in the pulsed mode. Color flow imaging is more sensitive than conventional PW Doppler for detection of aortic regurgitation. This patient has a bicuspid aortic valve. In diastole, we have been able to utilize color flow to detect the jet of mild aortic regurgitation. The original descriptions of Doppler semi-quantitation of aortic regurgitation utilized pulsed wave mapping to determine the length of the jet. Since the introduction of color flow imaging, we no longer use pulsed wave Doppler to semi-quantitate the regurgitation. Furthermore, we pay little attention to the length of the jet. Even mild degrees of aortic regurgitation can be shown to extend all along the anterior mitral leaflet and beyond. There is both in vitro and in vivo evidence that the most significant dimension of the jet, relative to its severity, is its width, assessed just below aortic valve level. In this case, the sclerotic aortic valve is mildly regurgitant. Note the very thin jet of aortic regurgitation that is directed along the anterior mitral leaflet. The assessment of the spatial extent of color signals from aortic regurgitation relative to the area of the proximal left ventricular outflow tract is best made using a peristernal short axis orientation. This patient has a three-cusped valve with very mild thickening along the closing edges. In this diastolic frame, the signals from mild aortic regurgitation are encoded in shades of blue and occupy a small area of the left ventricular outflow tract adjacent to the left coronary cusp of the aortic valve. An M-mode cursor has been directed through the regurgitant jet. This is the resultant color M mode, with a thin jet of aortic regurgitation occupying the lower portion of the left ventricular outflow tract throughout diastole. This patient has moderate aortic regurgitation. Note that the colored jet is wider than that in the previous case. This patient is in atrial fibrillation with a slow ventricular response. In real time, it will be apparent that the bradycardia increases the time for regurgitation. Mild mitral regurgitation will also be evident. In parasternal short-axis format, the area of the color flow jet again appears moderate relative to the area of the proximal left ventricular outflow tract. In real time, tricuspid regurgitation will also be present. Moving back to parasternal long-axis format, an M-mode cursor has been directed through the aortic regurgitation signals just below the aortic valve. On the color M-mode, mild mitral regurgitation is evident in systole. The aortic regurgitant jet is here. The color M-mode is a nice modality for assessing the width of the jet, as well as for timing of various events during the cardiac cycle. This is a 31-year-old female with rheumatic aortic and mitral valve disease with severe aortic regurgitation. This is a parasternal short-axis view of the three-cusped aortic valve. Note the small central regurgitant orifice. In the parasternal long-axis format, the jet of aortic regurgitation fills the full width of the left ventricular outflow tract. Associated severe mitral regurgitation will also be evident on the real-time display. Note the broad mosaic color jet of severe aortic regurgitation. The M-mode cursor has been placed through the regurgitant jet just below the aortic valve, and the broad jet of aortic regurgitation is demonstrated on the color M-mode throughout diastole. The severe mitral regurgitation is evident in systole. The mosaic jet fills the left atrium. Doctors Perry, Helmke, and Nanda from the University of Alabama, Birmingham have proposed a method for categorizing the degree of aortic regurgitation by color flow imaging. They assess the degree of aortic regurgitation by measurement of the colored jet and the left ventricular outflow tract. In the parasternal short-axis format, they measure the area of the jet and divide this by the area of the left ventricular outflow tract. In the parasternal long-axis orientation, they measure the height of the jet and divide this by the height of the left ventricular outflow tract. They have shown that these two quotients correlate nicely with the angiographic grade of aortic regurgitation, while jet length correlates very poorly with the angiographic grade. This is the grading system for aortic regurgitation that Dr. Perry and his colleagues utilized. This is a parasternal long-axis view demonstrating a jet of aortic regurgitation. The image has been frozen in diastole, and the instrument's calipers have been used to measure the width of the jet just below the aortic valve, 9 millimeters. The left ventricular outflow tract diameter has been measured at the same level, 18.8 millimeters. This yields a ratio of 48%, which is moderate by the previously displayed criteria. The transducer has now been rotated to develop a parasternal short-axis image. The image has been frozen in diastole, and the area of the jet has been measured by tracing its circumference. The instrument has calculated an area of 126 square millimeters. At the same level, which is just below the aortic valve, the LVOT area has been measured, 404 square millimeters. This yields an area ratio of 31%, which again falls in the moderate category. It is important that these parameters are measured just below valve level, since the jet usually fans out as it extends further toward the ventricle. One should not solely rely on color flow imaging for grading the severity of aortic regurgitation. We always seek supportive data using the continuous and pulsed wave modes. With continuous wave Doppler, we assess the severity of aortic regurgitation via the strength of the signal and via measurement of the pressure half-time of the regurgitant jet. As a general rule, the more aortic regurgitation present, the stronger will be the signal. This patient has mild aortic regurgitation. We had to struggle to define the full velocity envelope in diastole. Note that the systolic aortic signals are much stronger than the diastolic regurgitant signals. This patient has aortic stenosis and severe aortic regurgitation. Note the very dense regurgitant spectrum. In addition to the strength of the regurgitant signals, the diastolic slope of the CW spectrum also gives us important information about the severity of aortic regurgitation. This schematic shows pressure tracings of the aorta and left ventricle from patients with mild and severe aortic regurgitation. The shaded area is the diastolic pressure gradient between the aorta and left ventricle. In both cases, the initial gradient is large, which will result in a high velocity early in diastole, as we will see on the CW spectra. With mild aortic regurgitation, the left ventricular end diastolic pressure is normal. The pressure gradient between aorta and left ventricle at end diastole is still quite large. This means that the rate of change in the pressure gradient is small, and we would expect a prolonged pressure half-time. By contrast, in severe aortic regurgitation, the aortic diastolic pressure is low, and the left ventricular end diastolic pressure is elevated. These two factors result in a relatively small gradient between the aorta and left ventricle at end diastole. Consequently, the rate of change of the gradient from early to late diastole is relatively rapid, and we would expect a short pressure half-time. This patient has mild aortic regurgitation. The early diastolic velocity on the continuous wave spectrum is about 4 meters per second, correlating with the high early diastolic gradient that is always expected with aortic regurgitation. Note that the slope of the regurgitant profile is relatively flat. This slope has now been traced, and the instrument has measured a pressure half-time of 713 milliseconds. Various cutoff levels have been suggested in the literature for classifying aortic regurgitation via this CW technique. We have found that half-times greater than 500 milliseconds are consistently associated with mild regurgitation. This patient has moderate aortic stenosis and severe aortic regurgitation. The end diastolic velocity is low, which implies that there is a relatively small gradient between aorta and LV at end diastole. There is a rapid decrease in the pressure gradient from early to late diastole, as reflected here by the rapid fall-off in velocity. The top of the pressure curve has been traced, and the pressure half-time has been calculated as 165 milliseconds. We have found pressure half-times below 200 milliseconds to be consistently associated with severe aortic regurgitation. Having discussed the utility of color flow imaging and continuous wave Doppler in semi-quantitating the degree of aortic regurgitation, we will now discuss the utility of pulsed wave Doppler in this same context. The amount of diastolic flow reversal in the aortic arch provides insight into the degree of aortic regurgitation. Regurgitant fractions may be calculated by utilizing pulsed wave Doppler and 2D echo to compare flow in the left ventricular outflow tract with flow at various other positions in the heart, such as across the mitral valve. These measurements are quite tedious. We do not routinely use them in clinical assessment of aortic regurgitation. Severe aortic insufficiency will cause a reduction in the mitral valve deceleration time, which is also assessed using the pulsed wave mode. The flow reversal in the aortic arch can be demonstrated by both pulse Doppler and color flow imaging. This is a normal arch examination with the transducer in the suprasternal notch. The cursor in the descending aorta is generating this color M mode. Several cycles show slight, early diastolic flow reversal, encoded in red because the flow is toward the transducer. To accomplish the pulsed wave examination for flow reversal, we most commonly use a sample volume position in the descending aorta about a centimeter or so beyond the left subclavian artery. Here we are utilizing flow imaging to guide sample volume placement. This is the resultant pulsed wave spectrum. Systolic flow is recorded below the baseline. In early diastole, there is a brief signal above the baseline due to a physiologic amount of flow reversal. The remainder of the diastolic signal is below the baseline, indicating that the majority of diastolic flow is in a forward direction. Patients with mild aortic regurgitation might show this same pattern. We have not found this portion of the Doppler examination useful for separating normals from those with mild aortic regurgitation. This 61-year-old female has moderate aortic regurgitation. In systole, flow in the descending aorta is largely encoded in blue. This red area is due to color alias. These same findings are noted in systole on the color M mode. Flow reversal is noted in diastole. Rather than being a very brief color event, the flow reversal in this patient lasts for about 1/4 of diastole. A pulsed sample volume has been placed in the descending aorta. The spectrum shows that the early flow reversal has a relatively high velocity of about 0.6 meters per second. The velocity falls off to a minimum level by about 1/4 of diastole and then persists throughout diastole at a lower level. This latter velocity was too low to be demonstrated on the color examination. This pulsed pattern is typical for a moderate degree of aortic regurgitation. This patient has severe aortic regurgitation. Note the marked pulsatility of the arch. This is another characteristic of severe aortic regurgitation. In systole, the descending aorta is filled with blue-green signals representing forward flow. In diastole, the entire descending aorta is filled with red. This large amount of color reversal is due to severe aortic regurgitation. On the color M mode, note that the marked color reversal persists throughout diastole. On the pulsed spectrum, note that the flow reversal has a velocity of about 0.4 meters per second and persists throughout diastole. This is the pulsed wave examination from another patient with severe aortic regurgitation. As previously mentioned, severe degrees of aortic regurgitation cause a rapid and marked rise in left ventricular diastolic pressure. This not only contributes to a shortened pressure half-time of the aortic regurgitant signal, but also causes a marked decrease in the deceleration time of mitral inflow. The deceleration time here is 85 milliseconds. Normal for adults is greater than 160 milliseconds. This is the mitral inflow spectrum from the same patient following aortic valve replacement. The deceleration time has increased to 225 milliseconds. The effect on the mitral valve of the marked rise in left ventricular diastolic pressure due to severe aortic regurgitation can also be detected by M mode. This is the M mode from a patient with chronic aortic regurgitation. The jet is directed toward the anterior mitral leaflet, creating diastolic flutter, which is an M mode hallmark of aortic regurgitation. In this case, the mitral valve closes with normal timing, following the onset of the QRS complex. This is a case of acute, severe aortic regurgitation. The rapid and marked rise in left ventricular diastolic pressure has closed the mitral valve prematurely. This is a mitral pulsed wave Doppler spectrum obtained from yet another patient with acute, severe aortic regurgitation. The sample volume has been positioned within the mitral funnel. This is the mitral closing click, which is occurring well before the QRS complex. The click is followed by a signal of mitral regurgitation, which begins in diastole and then continues throughout systole. Diastolic mitral regurgitation is another finding that points to severe elevation in left ventricular diastolic pressure. When assessing patients with aortic regurgitation, we cannot rely solely on any one parameter as an absolute marker of severity. Rather, we must integrate all of the Doppler information that we can obtain from the left ventricular outflow tract, from the arch, and from the mitral inflow pattern. In addition, we must not ignore the very important information provided by measurement of the ventricular dimensions. This gives us the functional significance of the regurgitation. This is another patient with severe aortic regurgitation. The M-mode cursor is being passed through the left ventricle at chordal level. The left ventricle is markedly enlarged with a diastolic dimension of 87 millimeters and a systolic dimension of 54 millimeters. This corresponds to an ejection fraction of 65%. In addition to giving witness to the degree of volume overload, left ventricular measurements are critical for serial follow-up of patients with aortic regurgitation. On this tape, we have described the comprehensive echocardiographic assessment of aortic valve disease. For patients with aortic stenosis, meticulous application of the 2D and Doppler techniques that we have discussed will allow you to accurately determine the pressure gradient and the aortic valve area. For patients with aortic regurgitation, the integrated approach we have described, incorporating 2D, PW, CW, and color flow information, will allow you to accurately characterize the hemodynamic severity. Therefore, it is only a small minority of patients with aortic valve disease that now require invasive assessment of hemodynamics for clinical decision-making.